nice to hear the crowd noise. It's nice to hear happy voices and the sounds of people talking. And I understand that I might need to be a little bit louder. So how does that sound in the back? Are we getting there? All right. Well, again, thank you everyone for coming this morning. My name is Chad Noble, and for the last 15 years it's been my pleasure to host Breakfast for Business. As I was getting myself ready this morning, thinking about what my day could look like, it surprised me that for 15 years we've been meeting here. Actually, the number is close to 25. Next year, next January, will be the 25th anniversary of this thing that we call Breakfast for Business. And I've been privileged to be a part of it for the last 15 years. And as I look out among many of you, most of you I know, many of you have been a part of this for all of those 15 years. And for that, I thank you. And this is a good representative group of the community, and we appreciate your interest in Allegiance Health. And we hope that you find that these opportunities are good for networking, good for your business, and good for sharing information. And that's exactly why we do this at Allegiance. Our topic today is graduate medical education. And we have 4 presenters. And before I introduce those, I just want to go over a couple of housekeeping issues. On your tables are these kind of fluorescent green, you could call that an Allegiance green form. We're simply asking that if we didn't contact you by email, or you've had a recent change to your email address, we value your attendance at these, and this is our primary way that we make sure that we are inviting you to all things Allegiance. We promise not to fill your inbox with all kinds of announcements, but we want to be able to make sure that we have your correct email address. So if you think that might be incorrect, or you've had a recent change, if you'd let us know. Secondly, on your table, we have a 2-sided yellow card. On the first side is information about you, if you'd like to share that with us. And also, during the presentation on the other side, if you find that there's a question that you'd like to ask, we often use these question cards. So if at any point you feel like writing something down, at the end of the presentation, I will ask probably Debbie Eccleton, and Debbie is right in the back. Debbie, if you'll raise your hand. I'll ask Debbie Eccleton to come around, and if you'll hold these up, she'll bring them up to me, and I'll be sure and ask the question so that everyone has a chance to hear the question, and whoever the question is best answered by will get that question answered as well. We have a couple of VIPs in the audience this morning. Actually, all of you are VIPs. We have a couple of elected officials that I would like to make sure that everyone has a chance to know who are here. So if I could ask all of the folks who are here who are elected officials, and whether that's at the state level, the federal level, school board, community college, if I would ask you to now stand and self-introduce and introduce yourself so the rest of us can acknowledge you. So if you would please stand. Great. Well, can I start over on this side of the room with Representative Shirkey? Would you please introduce yourself and let us acknowledge you?
Representative Shirkey. Representative Earl Pileski.
Jim Starman, Supervisor, Grass Lake, Carter Township.
Dr. Ed Mattine, Trustee, JCC.
Good morning. Julie Alexander, Jackson County Commissioner.
Pete Jancic, Blackman Township Supervisor.
Laura Schlechte, City Council, Jackson.
Would you please give them a nice round of applause? As we all know, these folks give themselves tirelessly to make our community a much better place, and we appreciate them taking time out of their schedules, like the rest of us, to be here this morning. Again, I think we're ready to get things started, so what I'd like to do is to introduce our presenters today. Coming up first will be Georgia Potasic, President and CEO of Allegiance Health. Also speaking today will be Dr. John Lake, a local physician and a native of Jackson, and you'll be hearing from him, and also Pam Royston, who is our Director of Graduate Medical Education. Pam is a transplant to Jackson, but also is finding this a wonderful place to live, and many of you have made her feel welcome already. So without any more pause from me, Georgia, are you ready to go?
I am. Good morning. How are you all today? Isn't this a great place to look out on? Love being here. Thank you all. It's when I arrived in Jackson, Breakfast for Business had just started, and I thought it was an interesting thing that we were doing to be able to share services and things that were happening that were new at Allegiance Health. It's turned into something that I've really grown to appreciate in terms of what we learn from you all and the perspective that you're able to provide us in our own business. I can also tell you it's become a model for the state as others hear about the opportunities that we have to talk about the impact of healthcare and what we can do to make Jackson better. So I appreciate the fact that so many of you have been here for the majority of the 25 years we've been doing Breakfast for Business. We have a topic that we want to focus on today and that we're really excited about, and that's the graduate medical education program that will be starting at Allegiance very shortly. What I'd like to do is set the stage and a little context at a time when there's a lot of change going on in healthcare, and it's on the front page of the news nationally and statewide. First of all, we're going to post these to the Breakfast for Business website because I know this is a little bit challenging to see. But the environmental assessment of the dramatic changes that are happening in healthcare as we move from an era of pay for volume to pay for value, and we've talked to you about the crevasse and the perils that we will face, but we've had, as you all have experienced in your businesses and also personally, a very fragmented system of care that is based on paying for services or paying for volume. It's a sick care model, adversarial relationships between payers, which we've spent quite a bit of time talking about here, limited information systems, and a lot of waste and duplication. We're moving and are starting to experience an accountable care model with payments that are fostering wellness through global payments and bundled payments. Payers are more partners. All of this is fueled by electronic health records and information systems that actually mine the data to look at outcomes and best clinical outcomes so that we're getting the best care for our patients. Allegiance has been investing in movement to accountable care, whatever you want to call it, for at least 2 decades. We've been leaders in looking at chronic disease management before it was popular, because we knew that in our community we had high rates of chronic diseases that needed and would benefit from centralized care. We've had a very long-term strategy of electronic health records on the clinical side and not just on the business side. And now Allegiance is one of 4 health information exchanges in the state. We're a small one, but we do have an electronic health record here with a large number of you having your health records accessible to different physicians and different providers that you may be going back and forth to, moving away from the era of paper-based records. We also have had a long history, in part fueled by the relationships we've built at Breakfast for Business, of collaboration with our employers and trying to move away from the we, they, and being very transparent with you all about how our business model works and getting away from the win-lose of the shell game that employers win if the health system loses, and vice versa. And those have been big investments that we've made. And so when we owned PHP, we were making a lot of those changes and investments through the health plan strategy, and that enabled us, for example, to have the data to say that we needed to start investing in chronic care, disease management. That then led to our health improvement organization, where we really talked about investments in health and being able to fuel the economic growth, if you will, of this community by taking a pretty unhealthy population and being able to make investments to make it much better. And we continue that work today, and we've had a very nice group of employers working with us through the Business Leaders for Health. We've since then moved, and we shared with you at our last Breakfast for Business our partnership with our physicians through our clinically integrated network, and you heard from Dr. King and from Dr. Mike Klinkman, the physician at the University of Michigan, who's working with us. And that work with our physicians continues, and we're getting ready to launch at least one demonstration project with one of our payers that we hope to be able to share with you when we gather again. So what we are operating on is the assumption that health systems are going to undergo fundamental structural change, that there's going to be an increasing call for accountability and transparency, fueled with competition, not just the traditional competition, but Walgreens just announced recently that they felt like it would be a win for them and a win for communities, for example, if they became leaders in primary care. That patients could have primary care while they're purchasing their medications, and of course they would purchase more medications from Walgreens. And so that's the type of thing that in our mind, with electronic health records and with integrated team-based care, that is really taking us back to the care fragmentation and not to the partnership models. We know that consumerism is going to grow because people are becoming increasingly responsible for at least part of their coverage, and so there's the financial accountability. In addition, we're dealing with a much more sophisticated consumer. The older generation that grew up when the physician was the total captain of care, patients didn't ask a lot of questions. We've now moved to a baby boom generation of informed, educated individuals who also are caring for parents in a fragmented system. I've talked to enough of you, and I experienced it with my own father, to know that you really realize when you're helping an elderly person traverse the system that the system isn't a system. And so we're not wanting that for ourselves. So we know that leaders in system strategy and management systems are going to thrive and survive. So there's another piece of this last bullet on management systems and best practices that for those of you in manufacturing will wonder, and we've been pretty clear with you all, what took you so long? So we are now in the era of Six Sigma, lean thinking, and you know, I remember my early conversations with Bernard Levy when he was working very hard with JAMA, and he was so great to tell me, you just can't imagine how many times we got this wrong, figuring that we were on a path of improvement. So what we're seeing at Allegiance is this, is the same thing I think I was hearing from Bernard. We have had, for the last decade, successive improvement in our processes, leading to a lot of the national recognition that we talked to you about. So we've moved on various measures to the 100 top hospitals in the country, and these are all independent companies that mine Medicare data because it's the aggregated national data that's available to them. So we've gotten these recognitions for heart attack treatment, trauma care, etc., and most recently the Leapfrog, which is a coalition of national employers, a safety score of A. We've improved our processes, but you all know that sustained improvement requires a higher level of performance in terms of management systems, accountability systems, monitoring, the wise use of data, etc., and that's the stage that we're in now. We still have process variation and inconsistencies that, as you've experienced, can be a real problem for your business when you need to be a high reliability organization. One of the things that we will be sharing with you, and that is a little bit embedded in this leapfrog recognition as an example, is that taking the concept of high reliability systems that, and for us, the airline industry is a good model. We are applying those nationwide to our health systems, and so Allegiance is one of the early adopters of the concept of target zero, of zero avoidable harm to patients. And we are in the early stages of educating our staff, and it's just been a great experience for us to be able to look at ourselves in a fundamentally different way, and to ensure, just like any airplane that you would take off on, that any person on that plane can stop it from taking off if they have a concern. The quintessential team-based care where everybody has a role, and that fits beautifully with what we're doing with graduate medical education. So we're going to be bringing more of that, what we're learning and what we're, the results when we gather in the fall. And then the last piece of framing here about why graduate medical education is because we want to be part of the next generation of physicians who realize that care truly is team-based, integrated, and is fueled by information systems that are connected and usable. The history of healthcare over time, with some pretty low performance results, has been a craft age culture where physicians have their unique training in their medical schools and in their residencies, and then that's the way they work throughout their professional career. So you take a health system like Allegiance with 400 physicians on staff, all practicing a different craft. We're constantly adjusting to that, and that's where the variability comes in. And so this movement to the second curve, again fueled by information systems and the capacity to integrate, is the new era, and we are very excited to be able to have these young residents and medical students experiencing this new era of care in our community as we look at physicians who will be part of our future and our caregivers, and also part of the Allegiance culture. That's what's exciting to us, and you're going to hear more details. And then the other thing that to me in the graduate medical education that's important is that as a result of what we've done in transforming Allegiance Health from Foot Hospital is that we're ready. When I came here 24 years ago, I came from Texas Tech Teaching Hospital, and I wanted community hospital experience. And then when I got here, I saw that there was a void in not having residents and medical students around us, because they create a different environment and they keep you on your toes, and it's very stimulating. But we weren't ready. It was going to take a lot of investment in where we were and where we were performing. We had a lot of good people. We didn't have such good systems. In fact, we kind of didn't have many systems. And we've been working on putting those systems and processes in place for the last 2 decades, and now we're ready. You're going to hear from Pam and John Lake that these residents are ready and eager to join a health system like ours. And the other component of this, just as a precursor to what we'll also be talking about in the fall, is this readiness is around team-based care. And our movement to becoming a level 2 designated trauma center really revolves around saving lives with team-based care. And so what I want to tell you is that before we meet, we will have activated our trauma system. It takes about 2 years to become fully accredited. But we have one trauma surgeon now, our leader on staff, and at the end of summer or the beginning of fall, we will have started activating our trauma teams so that we will be able to more optimally have patients in our emergency department for resuscitation and stabilization. We're going to open a separate surgical intensive care unit that will be staffed by our trauma leaders, and we'll be managing the inpatient trauma care, coordinating care with multiple specialists, because these are patients who have been severely injured. And then we'll be developing discharge and rehab plans so people have the optimal ability to be able to recover from trauma. Trauma is the leading cause of death of those under 45. So it can really result in devastating losses for families and for communities. So with that, I'm going to turn it over to our team of Pam Royston and Dr. John Lake to talk about our graduate medical education program.
Good morning. You just got to figure out how to turn it on. Hi, I'm Pam Royston. I'm the Administrative Director of Graduate Medical Education. I've been with Allegiance Health for about 20 months, and I've really enjoyed the Jackson community, so thank all of you for welcoming me. I've got 20 years of experience in medical education, working both at medical schools and large academic teaching hospitals. So I was really glad to come back because I was out in Washington and I have 2 grandkids who live in Michigan, so it brought me closer to them. So thank you very much for this opportunity. This is my partner in crime, John Lake. Dr. Lake has been in this community. I'm sure most of you know him, and I couldn't really have put this together without his wisdom and support. He's been great to work with. We do have a unique partnership, I think. He gives me the microphone, I'll hand it to him, and we will trade off and on with what we're going to say. Thank you. So first of all, I gotta get over here. See, he tells me what to do, I do it. These are some of the questions that we have surrounding medical education. What is residency training? Why are we doing this? What's it expected to look like? Why are residents choosing Allegiance Health? How do the physicians feel about it? And what will patients notice? I'm sure that there's many more questions, but I think those are the top in everybody's mind. So as a quick reminder, I know we've been here before, but I'd like to share with you this path because it's kind of a long, grueling path. First of all, you start out with a bachelor's degree, 4 years. You go on to medical school, and believe it or not, I know for people in academia, this kind of sounds interesting because this is called undergraduate medical education, and we typically don't think about saying medical school is undergraduate, but when you get working in that field, that's what it really means. You have 4 years of medical school. When you graduate from medical school, these students are about $200,000 to $300,000 in debt. They are licensed physicians at this point in time, and they're going to continue on their training, which is the box where you can see the sleepy resident who is working about 80 hours a week. Usually you start out with a stipend of about $50,000, but if you do the math, it really works out to be about minimum wage while you're going through additional training in a specialty, which can take anywhere from 3 to 5 years. Once they pass this phase and they're working under the direction of our attending physicians, our supervising physicians here in the community, such as Dr. Lake, they go on, they're board eligible, and hopefully we will be able to retain them in our community. So why are we doing this? We really do have a national shortage of physicians in this country. Michigan is harder hit than some of the other states because we have a very mature workforce. And we're going to see a lot of people who are retiring. This stock market thing has me a little bit worried because with all of the growth now, I think they're thinking about it a little bit more sooner than what we anticipated. So we really need to get into this training model. When you train medical residents, typically they stay in the community where they're trained, so we're hoping that that provides a pipeline. The other piece that's very intriguing right now is that we are graduating more medical students than what we have residency training slots. There's a bottleneck on residency training. So we're getting into this just in time to help those students who are walking out the door. The other thing that will help us is that it will also leverage capacity in this community for us to see patients. So for example, we're going to be using the Center for Family Health as our continuity clinic for family medicine. You basically pull one supervising physician out, that's Dr. John Lake in the middle right there, and he's going to oversee 3 residents at one time. Those 3 residents will see 2 patients each during the same time that Dr. Lake would see 1 patient. So we're leveraging those visits. We'll also see more physicians in the hospital, helping our attending physicians. So we really are going to try and improve access to care. Now this is the unique part. When we first came and talked about graduate medical education, I believe we were under the assumption that we wouldn't open the doors until 2014. There was some change in legislation late August that allowed us to look at the feasibility of opening a year early. At that point in time, we had 2 training programs that were approved, family medicine and general surgery. We had 2 applications that were pending. One was emergency medicine and one was a traditional internship, which is a 1-year holding program for those people who need to go on to specialty training such as anesthesiology or dermatology, or they'll go back into what we call the resident match. Once we decided to open, we thought that we would probably be able to take in about 21 residents. If you can see the column on the far right, you'll notice that we are now going to be opening as of July 1st with 33 new residents coming into Allegiance Health. We will have 7 in family medicine. We've got 17 coming in emergency medicine, 3 general surgery, and 6 that are in that traditional holding program. So this is really intriguing. Everybody goes, why are they coming to Allegiance Health? And you know, it's really intriguing to me because, you know, Jackson has really got a lot going for it. We are positioned very well. The hospital has done a lot around quality and process improvement. It is very attractive when we start talking to those learners. The ability of our medical records, as Georgia pointed out, how we've got now most of the community with that electronic medical record, that's intriguing to them. They're really looking at what they're going to be able to learn here. The clinically integrated network, pieces that we're doing that are on the forefront, really have not taken off in other areas of Michigan, let alone the country, and they're looking at it as a great opportunity to invest in training. We have a different culture. We heard this over and over and over. When people come to Jackson, they said, we walk down the street, people are smiling at us. They don't even know us, they're smiling, they're talking to us. Yeah, they talk. And even in the hospital, they go, oh my goodness, people will smile. We don't know where they're going. They stop and they get us to where we need to go. They like it. They commented that the hospital is not sterile feeling. They liked being able to walk in and see some color on the walls. They've commented about what we've done for patient care. So all of those things make us a great training site for these people who are looking to further their education. We also have some great partnerships. The Center for Family Health, again, will be our continuity clinic, the Federally Qualified Health Center. We've had a lot of interest from these residents coming in that initiative. They like being able to see things integrated into a community and have that basically as part of their training. We also have a number of medical schools that we're working with, and so we've developed a pipeline now with medical students coming in to do rotations, to talk to our physicians and work with our residents, so that as we start, and believe it or not, we're not even taking them in the door, we're gonna start recruiting again in September. So that's how quick this turn of events goes. You're being awful quiet.
You're being awful talkative.
Okay, fine. I know. You just wind me up. So what are they saying about us? You know, we have had such great feedback from the residents who are coming here. I'm not sure if you can read this or not. We've got one that said, I've waited so many years, I almost can't believe this is real. I've read the email over and over again. I'm so grateful and honored and thankful. I wish I could move to Michigan sooner. And it's only 3 months and 25 days. And this came to us in March after we went through a resident match. I'm very excited about training at Allegiance Health and contributing to the formation of a high-quality general surgery training program. Allegiance Health embodies the kind of spirit that I want to see thrive in medicine. These are the comments. These are just a few of the comments that we've received of those trainees coming in. You ready?
Yeah.
I don't know if he is or not, but I'm going to turn it over. Can you handle the clicker too?
No, I don't need to click. What?
No, you don't. I'll handle that. Okay.
John Lake, I know a lot of you out here also, and I've been in this town for a little while, and I hate to admit it's been 61 years I've been in this town. But my point is what the difference the hospital is going to have. And I was trying to think of how I was going to present this to you all, and I think it's how people present to you. So if somebody walks up and they go, good morning, you're sort of, good morning. We're going to have 33 long coats and 4 short coats that are going to walk up and go, good morning, what are we going to learn today? And I'm sorry, that's going to be infectious. Physicians are going to respond to that, and they're going to love to hear that, and they're going to pick up their mood. We had a education program less than a week ago. The program was done at 6:45. Physicians sat around and talked till 7:30. Some about this, some about what's going on in their life, but if you know me, they talked, and I just love that. So that means communication is going to go up. You're going to love seeing these little guys come in. They're going to want to talk to you. They're going to want to know all that stuff. When you start talking to me about something I don't care about, they won't shut you down like I do. I'm going to love having the information that they give me. Everything is from that history. Every physician will tell you that, and they were going to get that complete history, and they're going to relay it to their trainers, who I'm happy to say is me. I have been looking forward to this opportunity since I came back to town. This town is ripe for residents. It's going to be great to have these guys walking downtown. I think downtown is going to explode with excitement because they're going to want to do things. They want to go out. They want to party. They want to say hello to people. So please say hello to them. They're lucky and they're happy to be here. This is going to bring a lot of, I actually asked somebody how I bring this on, but there's a lot of things going on in Jackson, and one of them is a collaboration that Allegiance and Consumers is doing to invigorate our town. That, on top of this residency coming with residents, this is 33. This is just 1 year. This builds over the next 3 years. This doesn't stay at 33. This is going to be a huge economic boom. I like to compare it sometime to Traverse City. I've been up to Traverse City since I've been born, and I think everybody that's been up there remembered when the big malls moved in, and everybody's wondering who's going to turn off the lights at Traverse. And then all of a sudden, Munson started some residency programs. And all of a sudden, some shops started coming into town, and that town is flourishing. This town will flourish again. I'm convinced. I am so excited about this, and I hope you're as excited as I am, and I hope when you see these guys, you smile, like Pam said, and say hello to them, because this is just going to be a turning point for us, I believe. Thank you.
You forget you're retired.
Oh, see?
We're team.
We're team. The interest not only lies just with the active physicians. I've talked to people that you've all known in this room and probably had dealings with that are also excited. It was kind of fun. If you were at the pink ball, we had one resident that spoke. We had 4 medical students there. I can tell you when I was a med student, nobody invited me to the country club for free food. But they all hovered at one point around Dick Van Scoik. And I don't know how many in this room's kids were raised by Dick Van Scoik. but he was in his heyday talking to these kids. And I talked to Dick about it. He goes, John, I haven't practiced in 20 years. What can I teach these kids? You teach them how to talk to parents, Dick. You teach them how to tell them about a sick child. John Axelson, hematology oncology, he's coming back. He's excited about this. If you know John, you know he's doing a lot of missionary work. He said, when I'm in town, I'll be there, tell me when. Art Ruinga, an ophthalmologist, is going to teach kids. Ada Bador, a neurologist here in town, recently retired, is looking forward to doing the lectures to our students to give them an insight of people that have been out there for 40 plus years. This is truly exciting things happening. I miss anything else?
No, I think you're good.
Now I'm done.
For the time being. Really, what will our patients notice? Well, John had kind of talked about this, but residents will spend a longer amount of time with our patients. And research shows that patient satisfaction goes up. They take time. Like he says, he goes, I won't cut you off. They won't. No, they won't. And the other part is they're learning too. So they converse at a different level. And they like to take the time to get to know their patients. Residents will also ask patients for feedback. They're learning. So you have the opportunity to develop these people in the type of physician that you want them to be. They will be getting feedback from everyone that they work with, and that's going to help in the development process too. So there'll be a lot of opportunity for our patients, their interaction, and they'll become the trainers of the next generation with our attending physicians. The impact is huge. John kind of alluded to this. When we're bringing in 33 people this year, that doesn't include their families. We have one individual who's coming in. He's got 5 kids. Do I have any? I did have school boards here. You know what that means. There goes the population of our schools. There goes the demand for services in the way of, groceries, housing. They're all looking at living in Jackson, and most of them have found places that are in Jackson County, so they want to live here. They like to be close. Again, it's that commute. We're going to have them on call. They're going to be working at night. They want to be within 15-20 minute drive to the hospital. This year it's 33. We're looking at adding, and eventually next year I think I projected about 60. It will go up the following year to about 90, grow to 120 to 140 after that. So the impact on this community is profound, and that it will generate about $18 million in direct cost and spin-off with tax base and also those other services that they will be taking advantage of. So the impact is huge. It impacts everyone. So we believe it's going to be a great thing. As I keep telling John and the other physicians that I've been working with, I said, it is the Y generation. And it's not just because of the decade that they're born in, it's not. They go around all the time and they go, why? Why? And John, remember when you were a resident way back when, not so long ago, and you asked the attending a question, what would they tell you to do?
Look it up.
You know why they said look it up, John?
They didn't know the answer.
Yeah, absolutely. We're going to have a lot of this going on, and as I keep telling people, I said, don't be fearful of this. This is exactly why you do residency training. It just pushes that knowledge all up. And again, they ask a lot of why. So it really will be good for the hospital in the way of our quality initiatives and continuing that quest. So thank you. Georgia, is this back to you?
Thank you both. A lot of energy there. And again, from one of our native sons and from a transplant. And we're very fortunate to have them both leading this program. What I'd ask you now is to give us those yellow cards. Give us your questions. We want to hear your thoughts. We want to hear what's on your mind. And I'm going to start out. I have a question for Pam. Pam, I have you come back up and take the microphone. You talked a lot about interaction between those of us in the room and these residents. There's an event coming up
Yes, there
that
is.
many of these folks might want to take part in. Can you tell us a little bit more about this? Because this is kind of a way for us to meet these folks.
No, it is exciting. July 16th, save the date. We are going to have a reception, and you will be invited to meet all of the new trainees that are coming in, all of the new residents, and we will have our medical students too. It will be at Allegiance Health in our new auditorium. It will be in the afternoons. I think it's by 4 o'clock to 7 o'clock. Stop in. You can also take a tour of the second floor of the Anderson building, which we are in the midst of renovation. And honestly, our construction crew are doing a wonderful job working 10 and 12 hours a day to get this done, because we need classroom space when these residents come in. So I can't tell you, my hats are off to them, but you'll get to tour that too.
By the way, we will be welcoming you to that by way of an invitation. So if you can write it down and put it in your planners, do that now, but we will be making sure that you're invited to that. Pam, also, John mentioned short coats and long coats. Can you help us understand what that means?
Yeah, I can. John, short coats and long coats. Short coats are medical students. They typically will have an embroidered logo from their medical school on them. They usually end at the hip. There's a big significant piece when you graduate from medical school, you go to a longer coat. And so the physicians that we have coming in, they'll typically choose either one that's down to their knees. A lot of times they get in the way, so they'll choose a 3/4 length coat. Those residents will have embroidered on their jacket, Allegiance Health. It'll have their name and their degree behind that. So you can definitely tell the difference when they walk in the room between who's a medical student and who's a physician in training.
Very good. Here's a question for John. Why is Dr. Lake so much slower that he can only see one patient when his colleagues are seeing two? Would you like equal time? That's just as it was read.
Isn't it nice he signed it?
I wasn't going to say.
I can only hope that you come in for your physical with me.
Pam, back to you on a serious question here. What medical schools are we working with, and where are these folks coming from?
Right now, we will have medical students that are coming in for their 3rd and 4th year of clinical training from Michigan State. We are also working with the University of Michigan, who is sending medical students for certain rotations here. We've talked to Wayne State to get their medical students coming in. We are also holding conversations with Central. They took their first class in right now, but they won't hit clinical training for another year or two. But they're looking at us to help with some of the hospital rotations. We're also talking with the Western and seeing what they need with rotations too. But they will be providing the majority of their clinical rotations through the Western campus. So we will probably get them here for electives. Anybody across the state, the country that is in a approved medical school that's either MD accredited or osteopathic accredited will be coming in for rotations. They typically like to come in before they start applying for residency. So our numbers really are going to swell in the fall with visiting people coming in to see what we've got available for different training programs.
Pam, I think this one also is to you as well. Talk a minute about the financial impact to Allegiance Health. We talked about the financial impact to the community, the economic benefits of having more families, more income earners here. Is there a cost to Allegiance? Will these folks see an increase in their premiums? How does this all work?
Wow, that's a really good question. And I could probably spend a whole week talking about the finance. Financing for residency is pretty complex, but I will tell you that Allegiance Health made an initial investment of approximately $4 million to get this project off the ground. It took a significant amount of money to do the renovation and to take about 2 years of salaries, fringe benefits for the physicians, myself, in order to get this up and running. Once we start training residents, we will have the opportunity for reimbursement through Medicare. Blue Cross Blue Shield contributes towards graduate medical education. There typically won't be any increase in premiums because it's funded by those two primarily. Medicaid also contributes to graduate medical education, but it's pretty volatile. So we haven't included that into our model. Expecting some of it, yes, but the primary focus of it right now is Medicare and Blue Cross Blue Shield. Medicare is one that really does carry the ball. We'll start having funds come in about the first year, so this upcoming year when we take residents, it will take us 5 years to develop that pathway to being fully funded by Medicare, so that we do see a margin coming out of graduate medical education. That's assuming that there's no changes. And again, as everybody knows, Medicare is being scrutinized right now, so there's a lot of talk with what's going to go on with graduate medical education and that funding.
Great. Here's a related question, although I don't know that this is specific to GME. It talks about it talks about reform and Medicaid and our uncompensated care. And will uncompensated care being compensated by Medicaid mean that premiums for employers will go down? Georgia, is this a question that you might want to address?
I'll start and then Janae. Do you want to help me? With the math. We have right now the fluctuation, if you think about the crevasse and the changes that are happening in healthcare reimbursement. There's money coming in and money coming out, and you've been working the math. So do you want to do the details?
Is this on? Okay. So with the Affordable Care Act, part of the plan is Medicare.
I'm sorry.
I'll introduce myself.
I just want to make sure everyone knows who you are.
I'm Janae Wickens. I'm the CFO and Strategy Officer at Allegiance. I've been here 12 and a half years and in healthcare for 25, and it is truly an honor to work for such a progressive, values-driven organization. So thank you. So, affordable care. The whole premise is Medicare spend is too high, so Medicare is looking to cut money out of the budget. And they currently provide hospitals what's called disproportionate share payments for treating those patients or providing reimbursements to those hospitals that treat an excessive amount of uninsured or underinsured. So uninsured or Medicaid. So Allegiance is a safety net hospital. And we currently receive about $10 million a year from Medicare for treating this population. So with affordable care, they're going to cut 75% of that. The backfill is Medicaid expansion. So the belief is if Medicaid is expanded, that then these individuals will have insurance and will have less charity care. Now the economists will say, are these two going to balance? We don't know. But, you know, a $7.5 million cut from Medicare for us is pretty significant. A 1% margin for us is $4.5 million. So it's a little over 1.5% cut. So our goal, or we're hoping that Medicaid expansion is approved by our state, because otherwise we have $7.5 million deficit that we have to make up when we're currently not making money now. Our operating margin is negative, so we have some challenges before us. So when we talk about crossing that crevasse, we're seeing declining volume, we're seeing declining in reimbursement, and we're also having to make investments in this transformation. So these short-term investments in GME and trauma, safety, population health through our clinically integrated network. So while our reimbursements and volume are declining, our margins are declining, and we're making investments in the future, because that's what Allegiance is about, is this community, population health, and being here to take care of our community. So that's the challenge before us. So if Medicaid expansion doesn't go through, Allegiance is facing some pretty devastating financial challenges on top of everything else with reform.
Okay, thank you. Perhaps you could brag just a little about landing our top resident choices. We are getting the best of the best from great medical schools. I think this is back to Pam.
Pam, will you talk a little bit about the match?
Oh,
Just-
yeah. Thanks, Georgia. You know, all I can tell you, Georgia asked me to talk a little bit of about the match, and for those of you who are not in medicine and have ever been a part of this, I'll tell you, it's gruesome. So what happens when they graduate from medical school? The medical students will go and they'll interview with different programs all across the country. They will then have a time period where they will rank order all of the programs in the way that they would like to go to that program. The program, on the other hand, puts together that same rank order list. And so they go through, they interview quite a few individuals, and they put a rank order list together. They throw it into what I would call this nice spinning wheel, and they crank it, and somehow there's a nice algorithm that goes through, and they'll line up. And if the resident or the medical student has the number one choice, the program has a number one choice, there's a match. And it goes through that process for about 20,000 medical student graduates. So at the end of match day, there are medical students who really don't have a position. You can be right there, so close to graduating, and you get the notice that you didn't match. Or on the program side, you can get the notice you didn't fill. And it's devastating. So match day is really very intriguing. Also, as I've told medical students, I said, don't put anything on that match list where you would never want to train, because I guarantee you, you'll end up there. You just will. It's Murphy's Law. And I've seen it happen. So we had 2 programs in the match, and I will tell you that for general surgery, they put a lot of time and energy into thinking of the type of individual they wanted to work with. We went through about 2.5 hours of training to develop questions, looking at behavioral indicators to find right fit. They were very interested in making sure that they had a total package. Not only academic, but that they had the right fit for the culture here, that they would work with them, because surgery is a 5-year training program. And we had about 60 applications for 3 positions. We interviewed about 30 of those, and we did get our top choice in surgery. So they are thrilled to be here. Our family medicine, we had the same sort of results. We went in to the match and we put in 4 positions. We filled all of those positions. Family medicine is a hard fill. So across the country, the fill rate is not as high. People from medical schools, they look at that. It's one of those specialties that have not increased in compensation. And so when they're looking at their debt load, a lot of them cannot afford to go into family medicine. They're choosing other specialties. So you'll see a lot of programs across the country that didn't fill. In Michigan, when they looked at us and they said, you're brand new and you filled, and we had different programs across the state, they wanted to know what we did. So we felt very, very fortunate. Emergency medicine was approved after the match, and we were waiting. Typically what happens when you go into the match, we have a lot of medical students who are applying for specialties that are very, very competitive and limited slots. Dermatology, anesthesiology, radiology, ortho. And yet everybody wants to be an orthopod. I swear, everybody goes to medical school, I'm going to be an orthopedic surgeon. Really? Come on. So typically what happens then is that you see after match a number of people who did not get a position. I will tell you, it was amazing. Within 12 hours with the match closing, I had over 100 applications coming in wanting our emergency medicine program. They wanted to be here and look at us because they felt that we had a unique opportunity to offer them top-notch people. And so we're very, very fortunate with that. Our traditional internship is a one-year holding place. Typically when people will take that, they haven't matched into the orthopedic surgery or dermatology. So they'll take a one-year training slot, go back into match. Our people that we took in for the traditional probably are in the 90th percentile of their boards and did not get a position. And so they're coming back, they're trying to stay in clinical activity because this next year, they never stop taking tests. They're going to be having to take another step of boards, and to be in clinical activity, integrated learning, it's going to help them with that board passage rate. So we were really very fortunate with looking at the type of individuals that we do have coming. I think they're very stellar, and I think you're going to be pleased.
Thank you for your good questions, and there's another one that kind of piggybacks on that. How did Allegiance pick the programs to train, and are we adding more specialties?
That's a really good question. Allegiance looked at it from a strategic standpoint of what are the physicians that are going to be needed in the community. So you really do an assessment of what you've got right now in the way of physicians. You look to see what your replacement rates are going to be and where we're going to be moving in the future. We try to focus on those areas of primary care. Family medicine, emergency medicine is getting hit, although it's not considered primary care. This emergency department within Jackson is used quite a bit. Our visits exceed many of the numbers that I've seen at level 2 trauma centers. So I think we're well positioned, and we need to expand that. We're also going to be looking at opening internal medicine in 2014. General surgery is an interesting field. When you look at it, we aren't training and keeping enough people in general surgery. So our real challenge is to keep these people in primary care, and when I say primary, it's keeping them in general surgery and not going on to specialization. And I think that's the piece that we're going to be looking at. We're not going to be a specialty training center. We will not emulate University of Michigan with subspecialty training. What we can do is provide great training, hands-on community training for primary care in those areas.
Pam, I want you to talk for a minute about a special case. This group wouldn't know about a program that we have at Allegiance Health called the SAFE Fund, and it's called the Staff Assistance Fund for Emergencies. And this is a way that Allegiance Health employees actually care for one another. Every year, and actually we're in this campaign right now, all of our employees are offered to take part in something called Circle of Strength, which allows us through payroll deduction and through one-time donations and use of our paid time off, we can donate to a fund called the Staff Assistance Fund for Emergencies. And if any one of our associates, any one of our employees has a financial need, they have the ability to confidentially go to this committee, and they review those things, and they review our requests, and they grant either loans or grants. Can you talk about what happened recently with one of our residents?
Absolutely.
Who technically was not one of us yet, but we decided?
As I've shared with you, you know, it's really intriguing. When you're in medical school, you borrow not only tuition but living expenses. You can't work while you're going to medical school. And so when you look at tuition, the average right now is about $45,000 a year, and then you're borrowing another 15 to 20 on top of that for living. Once you are past your financial aid piece and they look at it to see what those living costs are, you have no other money coming in. So when they graduate medical school from probably the 1st of May through when they get their first paycheck here in July, there's no income. There's no income. They have to be really good at budgeting. So the one individual that Chad was sharing has a family, 5 children. He was here looking for housing and staying with me while he was looking for housing. Yeah, I do that. And he had saved enough money for first month's rent and a down payment. He had to have his air travel. He rented a car to be able to peruse the area, and he had additional cash that was saved to help move his family to this community. He got a call the last day he was here that his father committed suicide. And he, again, immediately had to travel back to his wife and children and fly them across country to where this occurred. Again, limited funds and really a traumatic time with trying to put together flight arrangements that are not cheap, last minute. Even with bereavement, you had to prove a death certificate in order to get a reduced rate. So he took a lot of the money that he had set aside to be able to be with his family and get back across country. And so he was really worried about how he was going to make this transition to the community. And so our SAFE fund looked at this, and they said this was a unique circumstance, that this individual really did deserve help even though they hadn't been a part of Allegiance Health. And so they allowed him to put in an application and granted him the money. So it was very touching and very moving. So, thank you.
I think it speaks to our culture and how our employees at Allegiance are so excited about the residents joining us, that we, even though they're not here yet, we think of them as part of us. We want them to feel that way. Sounds like a great deal of communication is planned, but what metrics will be used to recognize the success of this program? How will we determine whether our GME program is successful?
You know, it's interesting because there's a lot of pieces that go on with training, looking at outcomes. So pieces that we will be tracking, we always look at how many applicants we get. We look at what board scores that they have. We also are going to be, in this first year, they have to sit for another national board exam. They also go through an in-training exam, which is a national exam based on the specialty. So we'll be looking at that. Again, the evaluation piece of this is really intriguing. Medical education is really revolving around feedback with these residents. So each time that they are on a rotation, there's at least 3 evaluations that get done. So we'll be asking patients for feedback. The attending physician that is with them will give them feedback. We also keep track of what they call behavioral indicators, and so we'll have a whole report card basically by program, looking at what our success rate is.
We have a question that goes back to one of our previous questions, and I think what I had asked was, where are these students coming from? Where are they students today?
Okay. That's really good. We have a predominant number that are from Michigan. So what our focus on was trying to get people who had Michigan ties. If we can get Michigan people to stay in Michigan, that's great. That's that pipeline. So we have a number of them that came from Michigan State University. However, when you go into this national match, it's throughout the country. I mean, everybody goes into it. And so we've got people that are coming from Washington, we've got people that are coming from Florida, we have people that are coming from the East Coast. Again, what we tried to do was find out, do you have a tie somehow with the community? Because again, we thought that would probably keep them here a little bit longer. So even though we said that, yes, you know, they are coming, typically they had some sort of tie, whether or not it was a spouse who had relatives that were living in Michigan, that they had done their undergraduate training here. We looked at those items too, but we have a predominant number, probably 50%, that are Michigan raised and wanted to stay in this area.
Doesn't answer the question. What schools are they coming from? This third time I've asked.
Michigan State University, College of Osteopathic Medicine. We have Nova, which is down in Florida. We've got Pacific Northwest University. We've got Rocky Vista, which is in Colorado. We've got Philadelphia College of Osteopathic Medicine. Those are the ones right now that I can think of, but predominantly the Michigan ones for residency will be Michigan State University College of Osteopathic Medicine.
And a second question, or a question that goes along with that, what do these folks look like? What's the breakdown of male, female, minorities, Latino, African American, etc.?
Wow, that's a good question. Well, I will tell you it's intriguing because I think we have a fair percentage that I would call non-traditional students. So they've got some life experience before they went into medical school. We've got one young woman who was a quality engineer with Ford who decided to go back to medical school. We have an environmental engineer who decided to go back to medical school. We've probably got, I don't think it's a 50-50, it's probably a 60-40 split. 60% are male, 40% are female. We have a good split between those who are single, those who have families. I don't know the minority breakdown. I would probably, I think probably 25% would be minority. But that might be low. I'm sorry, I just didn't think about preparing better for that question, but I think there's a wide variety that you will see here coming in. It really will be intriguing. I don't think we've got a large number of those who've gone straight from college, medical school, and then into residency. Most of them have done something in between, so they've either continued with a master's degree or have some real life experience before they've gone on to medical school.
Great. If the person who asked that question needs more information, we can simply get that. So either see Pam or I after that. And we're wrapping up here. Back to the example, and when you talked about the unmatched, I think that might have raised a question. In other words, if the match had happened and we got all of these applications through the unmatched program, or not through the match program, is this a concern to us?
No, it's really, it's intriguing. I think I did mention that we are on the cusp of graduating more students than what we have residency slots. You know, everybody projected that would hit in 2014-15. I believe it happened this year. I just came back from a national meeting and they were reviewing the data. And basically at the match, the National Residency Match Service came out and announced at that meeting that 1,200 U.S. graduates did not have positions after the match. That's a lot. Again, when you're thinking about it, these are people who've gone through at least 8 years of college, $200,000 in debt, and you can't practice medicine unless you've gone in and gotten at least a year of training and gone on to residency training. So those people are the ones that again, after everybody had filled, and it's kind of like a free agent type of piece. When you sign up to do the match, it's a legal and binding agreement that you will participate and stay in that match. So there's a whole time period that we can go and offer positions. Once that date is done, those individuals become free agents. And that's when we can see a lot of these people applying to our program. It's not really concerning, again, when you think of all of the people who are trying to get into specialty programs and very competitive programs where they just were not able to seek those positions and get in because of sheer volume this year. I think that next year we're going to even see that it's going to be even more of a challenge to those individuals. So really matches is kind of an opportunity for those programs to really wait and get those cream of the crop people that are really coming back through and giving us a second chance.
Okay. Looking at the clock, we're getting on to 9 o'clock, and our promise is to make sure that you all get out by that time. I've got 2 more questions, and they're similar, so I'll read both of these, and I think they can have the same answer. And then, Georgia, if you'd like a few minutes afterwards to close, we can do that too. What types of ancillary services do residents typically require, and what will Allegiance's role be? Are there partnerships being developed locally to address these? For instance, family needs, financial mentoring, so on. And then the second question, again related to that, or the second person asking the question, what is the best way to get in contact with these residents before they get here in order to offer our services?
Wow, that's a good question too. So I will tell you that residency training, there is a set of standards. It's like developing an academic institution in a hospital. So when I say that, there are pieces there that we have to have in place before we can even put in an application. We had to be able to show that we were able to offer resources to our residents. So we have a physician program for impairment that was in place. We ended up looking at our employee assistance program and making sure that our residents would be able to participate in those. As far as the financial needs of residents and their training, we also have to provide that throughout the training program. That's a part of the curriculum. So again, as they come in, as I keep telling people, I said, you know, they really just want to know their way around the hospital. They want to know how to get into the hospital, how to log into a system, and how to get from point B to point A to B, I guess. A little bit backwards there, huh? But, so we're really trying to focus on making sure that they've got the basics met before we go in and delve into those areas of personal finance. We do have a wellness curriculum that we're going to be rolling out in this first year. All 34 residents will be going through with myself and Dr. Aaron Foster, who's a behavioral health educator, psychologist, who is now working with the residency program, and we will talk about those pieces and basically get their input into areas of stress for them. Unless we ask them, we could be missing the mark. So as we go through this, we're looking probably in offering them financial counseling, building support networks, working with individuals within the health system, looking at opportunities outside, and really how to handle stress. One of the things that I shared with Allegiance Health and the leadership, our residents are 6 times more likely than the general population to commit suicide. The stress is that high. And so with this wellness program, we're trying to take aim at ensuring that we do have those resources available to them. As far as getting a hold of them right now, it's very difficult because they're all in transition. Most of them are graduating from medical school or have graduated. They have not been employed through Allegiance Health, and their access to email or even phone service is a little bit sporadic until they get here. So there's more opportunity as they get to Jackson. But again, our first week is really trying to get them acclimated and to the hospital, to the systems, and making sure that they know where to park and how to get into the hospital from point A to point B. It's a challenge at times. They have hallways all over the place and doors.
Pam, I want to just expand on that question just a little bit, because I think the audience are many of us business people. They're wondering if they can be involved somehow in the graduate medical education program. And if that's the case, or do we have examples of how we're working with different organizations in the community? And if someone has an idea as to how to become involved, would they contact you?
The best part right now is probably to contact me. Again, there are going to be opportunities, but I will tell you it's very limited right now with trying to figure out how to fit things into curriculum. Running this is like running a school, and we have to have so many hours of a certain topic each and every day, each and every week. And so as we look at where the needs are, we may be able to open that up more. We have been working with a lot of the people in the housing industry, trying to find apartments and rentals. That was a big concern right now. Again, as we go forward with looking at financial services and financial planning, that may be another area. We've talked to the different educational partners around the area to see where we can partner, such as simulation training, libraries, schools. We will be trying to expand that more, but I think right now it's trying to figure out how to get residents really acclimated. If you do have information, what would be very helpful is if you could get it to us by June 21st. They're going to be going through orientation. They're going to get a bag of information. We've used the Chamber's information of putting together a welcome packet, but if there's particular information that we could share through that, that would probably be the best way.
Thank you, Pam. Thank you, Pam. Thank you, John. And Georgia, would you like to take us out?
I just want to, I think some of the questions that were asked are related to your business interest, and we're new at this, and just as a reminder, this was since last August that we quickly said we were going to do this a year early. So we've devoted a lot of resources to doing that early, but I think we have more opportunities to coordinate. We have worked with the Chamber, but when we have a community reception, it's an obvious opportunity for you all to introduce yourselves, and so we encourage you to come. We can continue working with the Chamber, and as we get some experience and get over this hurdle of this initial time, then I think that there are going to be opportunities for us to coordinate better with the business community more optimally. And we commit to doing that because we want this to be a key part of economic development. I also want to say, because I want to clarify, I think some of the real themes of questions were, are we getting the top of the top, or are we getting the bottom of the draft? We only had 2 programs of the 4 that were ready for the match, and so the emergency department, which is a very competitive specialty, we had the opportunity because of timing and the shortage of residency slots to go back and get some of the top emergency department residents and have 3 years of residence. And Pam talked about the osteopathic training. When we decided to take advantage of this advanced year, the MD or allopathic education is a longer credentialing process, and so we weren't ready. Our goal is to have both programs, MD and DO, available in our community, so that will be part of our future as this goes on and we move from the 33 residents to 140-ish residents. And there are opportunities we see to make that number even larger as we go through this startup period. I also wanted to mention that what we're starting to hear from these young folks and what we experienced in Lubbock is once this goes, the residents start by, one of them already told us this. I was told to buy a home, and by her fellow medical students and residents. So what they start doing is they buy homes and then they sell them when they finish to the next incoming resident. So we start seeing little villages of where residents are, and that's great because then they have support systems and networks. So this will become a community where there are folks coming in and folks coming out all the time, and that will be transformational for us. And Chad mentioned our, and Pam, our partnership with consumers. What we're wanting to do is to come up with increasing ways for these individuals to choose to purchase homes and have residences in Jackson. And so that's part of what we're working on with the new people coming in with HCL at Consumers Energy, and we're trying to coordinate and collaborate through that so that we get maximum community benefit. The last thing I would mention is that we are picking individuals that we want to be able to stay in Jackson. So as we have physicians who retire, that we actually are interviewing over the course of time people that we think would be great for medical care in our community. We intend to spoil them to Jackson, and I invite you to do the same. They need to know about us. Those of us who live here and love living here know this is a great place. Those who don't, don't. And we have an opportunity to tell a lot of people from throughout the country how great this is. For those who don't stay here, they will still take a piece of them with them. And they could be in Topeka, Kansas, or Seattle, Washington, talking to somebody and saying, you know, the community of Jackson, Michigan is really wonderful. And that's what we want, because we are. So thank you all very much for being here and helping us.